Hi everyone, today I'm going to review the first chapter of the Tononto Notes 2025, Cardiology and Cardiac Surgery. Moving into our basic anatomy review, let's focus on coronary circulation. The conventional arterial supply to the heart begins at the root of aorta, specifically arising from the right and left aortic sinuses of Valsalva. From here, the network splits into two primary pathways, the right coronary artery, or RCA, and the left coronary artery, the LCA. If we look closer at the RCA, its main branches include the conus artery, the acute marginal branches, the AV nodal artery, and typically the posterior descending artery, also known as the PDA or PIV. On the left side, the LCA quickly divides into two major branches. First is the left anterior descending or LAD, which further gives us septal and diagonal branches. The second major branches is the left circumflex or LCX, which gives rise to the obtuse marginal branches. An important concept to master here is the dominance of coronary circulation. This is strictly determined by which artery supplies the PDA. For the vast majority of people, about 80%, we see a right dominant circulation, meaning the PDA and at least one posterior lateral branch come from the RCA. About 15% of population has a left dominant circulation, where this vessel arises from the left circumflex instead. The remaining 5% have a balanced or codominant circulation, where the RCA and left circumflex share the job of supplying the posterior inferior left ventricle. Next, let's look at the electrical conduction system's blood supply. The SA node is fed by the SA nodal artery, which comes from the RCA 60% of the time, and the LCA 40% of the time. The AV node, however, is heavily reliant on the RCA. 90% of the time, it's supplied by the AV nodal artery arising from the RCA and only 10% from the left circumflex. Finally, looking at the venous side, most deoxygenated blood from the heart drains right back into the right atrium through the coronary sinus. However, a small amount drains directly into all four chambers via the Thebesian veins, which contributes to a normal physiologic right to left shunt. Let's review the foundational anatomy of the heart, beginning with the coronary arteries as seen in a right anterior oblique projection in Figure 1. The blood supply originates from the root of aorta, splitting into the right coronary artery or RCA and the left main coronary artery, the LCA. Looking at the RCA, it travels down the right side of the heart, giving off the conus artery and the AV nodal artery before branching into acute marginal vessels. It typically terminates as the posterior interventricular artery, also known as the posterior descending artery or PIV. On the left, the short left main coronary artery quickly bifurcates into two heavy hitters, the left circumflex artery, which wraps around the back and gives off obtuse marginal branches, and the left anterior descending artery or LAD. The LAD travels down the anterior interventricular groove, sending off septal perforators deep into septum alongside diagonal branches supplying the anterior wall. If we zoom into the base of the aorta in figure 2a, we find the complex anatomy of the aortic root. The aortic valve itself consists strictly of 3 leaflets or cusps. However, the aortic root is a broader functional unit. It encompasses everything from the ventricular-arterial junction up to the sinotubular junction. This includes the sinuses of Valsalva, where the coronary ostia originate, the interleaflet triangles, the annulus, and the leaflet attachment themselves. Moving over to figure 2b, we have a posterior view of the mitral valve apparatus. Unlike the tricuspid or aortic valve, the mitral valve is bicuspid, featuring a large anterior mitral leaflet and posterior mitral leaflet, which are bound by the anterior and posterior mitral annuli. Where these leaflets meet, we find the lateral and medial commissures. Notice how the structural integrity of this valve relies heavily on the subvalvular apparatus. The chordae tendineae anchor the left leaflet directly to the powerful anterolateral and posterior medial papillary muscles anchored within the left ventricle. Finally, figure 2c gives us a superior bird's eye view of the fibrous skeleton of the heart, which acts as the structural and electrical backbone of the organ. Here we can see the relative position of all 4 valves. Anteriorly sits the pulmonary valve with its anterior, right, and left semilunar cusps positioned just above the conus arteriosus. Directly behind it's the aortic valve, flanked by the tricuspid valve on the right and the mitral valve on the left. Tying this entire framework together is a dense network of connective tissue, the right and the left fibrous trigones, and the right and the left fibrous rings. This structural skeleton not only anchors the valve cusps and prevents them from over-dilating, but it also provides crucial electrical insulation between the atria and the ventricles. Let's transition into our core cardiac anatomy, starting with the structural layer of the heart from the inside out. The cardiac wall is composed of the cardium, endocardium, the muscular myocardium, and the epicardium. Surrounding this is the precardial space, which includes the visceral precardium, the fluid-filled precardium cavity, and the outer parietal precardium. Next, let's look at the 4 internal valves, which ensures a strict one-way flow of the blood. First, we have the semilunar valves, each comprised of 3 leaflets that separates the ventricular outflow tract from the greater arteries. The aortic valve contains a non-coronary cusp, a left coronary cusp, a right coronary cusp. With the right and left cusps housing the coronary ostia, this valve separates the left ventricular outflow tract, or LVOT, from the ascending aorta. The pulmonary valve features an anterior left and right cusps, separating the right ventricular outflow tract, or RVOT, from the pulmonary trunk. In contrast, the anteroventricular valve rely heavily on the subvalvular apparatus made up of chordae tendineae and papillary muscles to prevent regurgitation. The mitral valve is a bicuspid featuring an anterior leaflet that spans about 2/3 of the valve area, but only 1/3 of the circumference, and posterior leaflets that cover the remaining 2/3 of the circumference. It separates the left atrium from the left ventricle. The tricuspid valve consists of 3 leaflets, anterior, posterior, and septal, and separates the right atrium from the right ventricle. Now, let's trace the electrical network of the heart as illustrated in Figure 3. The cardiac impulse originates at the SA node, or primary pacemaker, located at the junction of the crista terminalis and the opening of the superior vena cava at the roof of the right atrium. From the SA node, impulse travels across the right atrium via 3 internodal pathways, the anterior, middle, and posterior tracts. Concurrently, the impulse travels across to the left atrium along Buckman's bundle. These atrial impulses coverage at the AV node, which is safely tucked into the triangle of Knock. This triangle is anatomically demarcated by the superior margin of the coronary sinus, the tendon of Todaro, and the hinge of the septal leaflet of the tricuspid valve. The AV node serves as the crucial gated conduit for the electrical signals traveling from the atria to the ventricles. Unless, of course, an abnormal as accessory pathway like a bundle of Kent is present, as seen in the Wolff-Parkinson-White syndrome. From the AV node, the signal passes into the bundle of His. This bundle quickly divides into the left bundle branch and the right bundle branch. The left bundle branch further splits into distinct anterior and posterior fascicles. Finally, the right bundle branch and the fascicles of the left bundle branch gives off the rapid-firing Purkinje fibers, which efficiently conduct the electrical impulses directly into ventricular myocardium to trigger coordinated contraction. Finally, let's tie this anatomy and electrical conduction into mechanical action by looking at the classic Wigger's diagram in Figure 4, which charts pressure, volumes, and electrical events over time. We begin in late diastole, where the mitral valve is opened and the left ventricle is filling. When the SA node fires, we see the P wave on the ECG, triggering atrial contraction to the top of the ventricle. As the ventricles depolarize, marked by the QRS complex, ventricular pressure sharply rises, causing the mitral valve to close. This creates our first heart sound, S1. This initiates the period of isovolumic contraction, represented by the first gray vertical bar, where ventricular pressure surges while ventricular volume remains completely unchanged. Once left ventricular pressure exceeds the pressure in the aorta, the aortic valve opens. Blood is rapidly ejected, causing ventricular volume to plunge and aortic pressure to mirror the rising ventricular pressure. As ventricular repolarization begins, marked by the T wave, the ventricle relaxes. As ventricular pressure drops back below aortic pressure, the aortic valve snaps shut, generating our second heart sound, S2. This marks the onset of isovolumic relaxation, shown in the second gray vertical bar. During this brief phase, all valves are closed, and pressure drops drastically until it falls below left arterial pressure. At the exact point the mitral valve opens, ventricular volume begins to climb and the cardiac cycle resets. Let's explore cardiovascular innervation, focusing on how the autonomic nervous system tightly regulates heart function and vascular tone through its sympathetic and parasympathetic branches. Starting with the sympathetic nerves, these fibers provide extensive innervation to the SA node, the AV node, the ventricular myocardium, and systemic vasculature. When sympathetic activity increases, it works primarily through beta-1 adrenergic receptors located at the cells of the SA node to drive up cardiac output. First, stimulation of SA node via beta receptors triggers more frequent impulses from our pacemaking cells. This increases heart rate, a concept known as increased chronotropy. Second, targeting the cardiac muscle fibers itself increases the force of contraction or inotropy, which directly leads to an increased stroke volume. On the vascular side, stimulation of beta-1 and beta-2 receptors in the skeletal and coronary circulation causes vasodilation to optimize blood flow where it's needed most during stress response. Now let's contrast that with the parasympathetic nerve. These fibers innervate the SA node, the AV node, and atrial myocardium, but notably, they supply very few vascular beds. When we are at rest, vagal tone heavily dominates over the tonic sympathetic stimulation of both the SA and AV nodes. This high parasympathetic tone results in a slow AV conduction, clinically manifesting as a prolonged PR interval, or in extreme cases, a second or third degree AV block. This slowing of conduction velocity through the AV node is termed reduced dromotropy. Finally, because the parasympathetic system has such sparse distribution to the blood vessel, it's worth nothing that it has very little impact on total peripheral vascular resistance. High-yield terms to emphasize: chronotropy, heart rate, sympathetic, increases it; inotropy, contractility, stroke volume, sympathetic, increases it; dromotropy, conduction of velocity, parasympathetic, vagal tone, decrease it. Thanks for your attention.